Hello and welcome to Newsmakers. I'm your host, Lisa Pugh. May is Mental Health Awareness Month, and despite recent targeted improvements in mental health supports, Wisconsin still has higher suicide and overdose rates than neighboring states and a worsening youth mental health crisis. Today we are sitting down with Tim Saubers, who is a person with lived experience and a professional peer support specialist, also chair of Wisconsin's Protection and Advocacy Council for people with mental illness, and Dr. Richard Immler, who is an adult and child psychiatrist and chair of Wisconsin's Council on Mental Health. Thank you both for joining us today.
Thank you.
Thank you.
Dr. Immler, in your recent report to the Council on Mental Health, you provide an overview of the state of Wisconsin's behavioral health system and list a series of challenges, including inadequate access, overuse of state hospital beds, major gaps in the system, inequities for people of color, increasing incarceration rates. Is Wisconsin's behavioral health system broken?
Great question and very complicated, so I'll try to be brief. It's not really a system in the best sense of the word. It's a 50-year-old model that's based on a county service model.
Which some other states have county models.
Exactly. County authority states, there's about 12. But things have changed in 50 years. And so in addition to the higher end services, the hospitals and the crisis services and community treatment, we've learned that early intervention and prevention can make a real difference and reduce death and disability. So there's a lot of room to expand that system beyond the county services.
So there's some things working and other areas that could be improved. So it's not broken, it's fixable?
Oh, unquestionably. Tim's work as a peer specialist and leader is a great example. Wisconsin's done heroic work in terms of the development of peer specialists. And some counties are really outstanding in the work that they do. There's other counties that really struggle, and so there's great variability across the state.
So depending on where you live, you might have access to better supports.
Yes. And the health systems vary in terms of their availability and the local providers as well.
So Wisconsin maintains a mental health dashboard that really just tracks the provision of county behavioral health services. We're looking at some of that most recent data there now. More than 68,000 people served by county services in 2020. The top 5 most used services: crisis, outpatient counseling, medication management, comprehensive community services, and case management. Tim, when you look at that list of services, what's missing for people?
Well, I think what's within there, I think there's a lot of space for growth in terms of access to services. What's listed out there are some really specific services that are covered only for a handful of groups, right? Specifically, like comprehensive community services is a case management level that is only available to people receiving Medicaid. And so with a lot of those services, they're not accessible to everyone. So I don't know that I necessarily see a ton of things that are missing. Of course, we'd love to see an increase in access to peer services, to community and demographic specific, culturally relevant services that maybe look different. But I would say in terms of what's actually listed there, the problem isn't necessarily what's being accessed, but who has access to them.
So there's a lot of people that fall through the cracks.
Mm-hmm. Definitely.
You mentioned peer supports, Dr. Immler. You talked about how Wisconsin has really grown their peer supports. Tim, this is your area of expertise. Mm-hmm. What are peer supports, and do you also agree that that's something Wisconsin is doing well?
Yes, let me start by saying that's something I think Wisconsin is doing extremely well. There's always room for growth. However, so far we've seen really exceptional work. But for those who are not familiar, a certified peer specialist is a person like myself who has lived experience navigating mental health and or substance use challenges, who has then completed Wisconsin's state certification program. It's a professional certification that is backed by the Wisconsin Department of Health Services in order to provide professional behavioral health care services within comprehensive community services, community recovery services. There are a few other levels of case management where you can provide Medicaid available peer support services.
So what does that look like in practice if I'm someone who is experiencing a mental health concern and I connect with a peer support specialist? What does that look like?
So it looks really different than what you might see with like a therapist or a psychiatrist. It is specifically a non-clinical model. And so the idea is centered more on having shared experiences than it is on alleviating quote-unquote symptoms or addressing what could be considered a clinical diagnosis. It's really centered on how do I support this person to build a life that has meaning and value to them, regardless of whether or not they continue to experience mental health challenges or they continue to use substances. The goal is to create a life that has meaning to them, with the hope that, in doing so, they might choose to reduce their use or make different choices, but those things aren't the goal. And so there's a lot more focus on empathy, mutuality, genuine human connection. That's really at the center of peer support, is how do I build a real relationship with this person who I view as a whole person with meaning and value, rather than how do I get them to stop using substances or to stop feeling so depressed or to take their medication. Those pieces don't really come into play when it comes to peer support.
And the evidence supports that this works.
It does, yes. There is an evidence base specifically for mental health peer support that shows very positive outcomes, that shows that centering services in that model really, really does work to improve people's lives.
Dr. Immler, Wisconsin has also increased what are called peer-run respite. Is that correct?
Yes.
How is that working across the state?
My understanding, I haven't been directly involved, but my understanding as well, in fact, the demand is such that we really need to increase that capacity. The warm lines also that these programs offer are really very valuable because it's run by peers. So it's working well, and I think the consistent movement is toward more access throughout the state.
More trained peers than supporting people.
And locating the facilities can be a challenge because in some instances it's been a not in my backyard with a misunderstanding of potential problems that those programs would offer, and that really hasn't been the case.
Mm-hmm. We mentioned at the top of the show Wisconsin's suicide rates, and in Wisconsin, and this was another thing in your report, suicide rates have been higher than neighboring states, higher than the national average. We're looking at some data from the state showing the trends from 2002 to 2020, kind of a significant increase over the last 10 years, and I think a lot of states experienced that throughout the pandemic. Dr. Immler, what contributes, do you think, uniquely to Wisconsin's high suicide rates?
I don't know if anyone can say precisely, so the hypotheses are several. One is access to care, that the early intervention that was mentioned earlier and preventive services, which are in some ways beyond the scope of the county-based model and the way that DHS is allowed to structure, make it difficult. So access to care, the prevention. We are expanding school-based mental health, which is encouraging because there's such a real need there. Another clear factor is access to lethal means. There's consistent research showing when there's access to guns, there's many suicide attempts that are not lethal, serious, but access to firearms increases the likelihood that someone will die of suicide. So that's a factor. Rates of alcohol use are contributory. Things that are disinhibiting can be a factor. So many, many factors. Also, if you have a population where they experience social inequities, trauma, as exemplified by adverse childhood experiences, you have a vulnerable population. And if we aren't targeting the needs in that population, then they tend to evolve into a more serious state. If there's not access to services, then the outcomes aren't good.
Tim, do you have thoughts on Wisconsin's disproportionately high suicide rate?
Yeah, I think there's definitely a big piece here in that I feel that there's a lot more space for the voice of people who have that lived experience of having attempted suicide to play a role in the development of what these responses look like. I know one of the things, a really big initiative in Wisconsin is that Zero Suicide Initiative. But as the data shows, we don't necessarily see it really working. And so I think that there really needs to be major reforms when we're talking about why people are feeling the need to end their life and creating space in behavioral healthcare systems for those conversations to take place without fear of a psychiatric incarceration or law enforcement engagement or an immediate safety assessment. I will say, as someone who, with lived experience with mental health, I have attempted to end my life before. And what I needed then wasn't to be forced into the hospital. What I needed was the community to be able to catch me and provide services and supports. I needed to not have to take time off of work. I needed to not have to take time off of school. But the way systems are designed right now makes it so that you have to do those things. So when we talk about accessing services, it's accessing a punitive service. It's accessing a punitive system that isn't looking at you as a human anymore the minute you say you're having thoughts of ending your life. It's immediately, what about our liability? What about, our organization? What about me as a provider? Rather than, what does this person actually need right now in order to feel safe and navigate through this experience?
That gets back to what you were saying about Wisconsin's kind of outdated system and those gaps and the need for reform. One thing over the last 2 years with the pandemic has really shed a light on and increased conversations about behavioral health needs. I was reading the World Health Organization released a brief last month saying that globally that prevalence of anxiety, depression increased by 25% during that first year of the pandemic. How do you see the pandemic changing conversations around mental health?
Excuse me. I think it's opened the conversation in some ways and has also, again, undermined them in some other ways. We've really seen the response being focused more on seeing these quantitative increases in major depressive disorder or generalized anxiety disorder, these clinical diagnoses, seeing an increase in overdoses and a return to substance use. And the focus has really been there. Whereas I think what we could really be using this opportunity to talk about is a little bit about what the doctor mentioned around trauma. Like, we are experiencing a global trauma together. So feelings of sadness, feelings of anxiety, feeling overwhelmed, those are all natural human experiences that don't necessarily need to be clinically diagnosed in order for someone to be supported through and navigate through. Additionally, if we focus it more in that way of you're just having a natural response, there's more space for people to receive support in their communities, in their homes, with their families, rather than having to navigate an overburdened system.
Dr. Immler, thoughts on the impact of the pandemic on mental health conversations?
Well, the WHO report was well done, and the fact that it's a global analysis is certainly true. The grief and loss in so many communities, and disproportionately communities of color, is serious, and the social isolation, especially for youth. There's been a greater impact on women around childcare and economic issues. So many factors that have come together. I may say this, I think my bias is a real collaborative approach with peer supports and the clinical community. And I think there's an opportunity to strengthen that. I wish I had reached out to Tim earlier because we become siloed, and when we work together and really form a team, there's limitations on what clinicians can do, and there's a great deal that peer supports can offer, and hopefully the evidence-based practices we can offer make a difference, so that team approach works best.
According to county health rankings in 2019, Wisconsin had a ratio of mental health provider to individual of 490 individuals to one mental health provider. And in other states that are doing better, that ratio is 290 to 1. You work on workforce issues and training of the mental health workforce. Are we in a crisis in Wisconsin?
I would say we're in a crisis probably nationally in terms of just anyone wanting to receive services. It's so hard to find a provider, and there are just so many reasons for that. I mean, looking back at Wisconsin in particular, if you look at how people are paid, it's just a chronically underpaid workforce. But also, to link it back to what we discussed earlier with some equity issues, there's major inequities in terms of who has access to trainings, who has access and the funds to pay for schooling that it takes to become a licensed clinical social worker, a clinician. That's years of schooling, an internship, that's field hours, that takes so much time that you're not really getting paid for. To become a certified peer specialist, it's 48 hours of training, but then it's, your wages are sometimes as low as $12 an hour. And so we're asking people to do really deep, meaningful work without recognizing their right to make a living wage, and not just a wage where they can live, but they can thrive and survive. So we've talked a lot about what could unionizing the workforce look like, what could collective action look like, how do we as a workforce take back some of that power, but I would definitely say that we're in a crisis right now.
There's also a shortage of psychiatrists, and there's been historic attention to the shortage for child psychiatrists. Is that right? What's the state of things now? Is it getting better?
It's getting a little better. Having been a child psychiatrist in the northern part of the state where for some years I had a 2-year waiting list to see new kids. And the way we were able to deal with that is close collaboration with excellent primary care providers so that they could call me anytime. But it's just a severe crisis and so many factors contributing. I will come back to the team-based model of care. Generally, by the time someone sees a psychiatrist, their needs are more complex. And if we're operating not just out of an office with medications, but able to say, well, I'm aware of this program that Tim is working with, and I'd like to connect you with local resources or community support services if it's appropriate, or local NAMI. But it's very difficult with a fee-based model that's production-oriented to have the time to be more holistic in that care.
Because your time isn't paid for in that collaboration piece?
It's limited to none.
That dashboard with the county-based services also kind of outlines what service needs are, and we see that short-term situational supports were in greatest demand in 2020, then followed by ongoing lower intensity and then ongoing high intensity use of services. Again, just tracking the county-based services. You come from Minnesota, or you spend some time of your career in Minnesota. Wisconsin has a county-based system. So does Minnesota. Minnesota recently underwent a series of reforms, and now they have half of Wisconsin's rate of state hospital bed use, and also 1/10 of the use of state hospital beds for youth. What is Minnesota getting right that we aren't doing?
Great question. Again, complicated answer, so be brief. One is really leveraging Medicaid. They had begun to do that 25 years ago and were able to use community hospital beds instead of referral to the state hospital. So the length of stay was much shorter and the connection to local supports much easier. And then it evolved into a really broad collaboration where consumers and advocates, family members, providers, counties, state, payers, hospitals came together over 4 years to say, what does the consumer need? So let's develop a model mental health benefit set, which was actually recommended in the management group report in 2009 for Wisconsin. So it isn't which program you qualify for based on your severity, as Tim alluded to, but it's based on where's the consumer located, let's say in their health system. And can that service be based there in more of a health home model? So that took a long time with all the stakeholder involvement and years of refining and refining and refining, recognizing folks at a county level do a great job, but they're really limited for many reasons. And that if we have a system that's broader than the counties, more holistic and consumer-oriented, it can make a difference.
You think other states are doing better with their systems?
I would say definitely. It's so tricky in Wisconsin to get all 72 counties to agree to do anything, right? And even with peer services, they were rolled out on a county-by-county basis. And while it works pretty well now, it was certainly a tricky process to navigate. I couldn't agree more with what was just shared, that that kind of home-based health services is best, as well as keeping people where they're at and getting them services as quickly as possible.
In July, Wisconsin launches a new crisis line, part of a national initiative, the 988 Suicide and Crisis Lifeline, that will allow people to call, text, do online chatting. Mm-hmm. Do you have high hopes for that, or what are your thoughts about that new crisis line?
I think the hopes are always high. The expectations may not be quite as high. Mm-hmm. I would hope that it's going to be a really exciting new resource, but as I talked about earlier, when it comes to navigating crisis, so often there are specific words or phrases that trigger the person receiving the call on the crisis line having to call emergency services or get other people involved that the person who's calling for help might not actually want. So while I do think it'll be great that people have a space to call, a big piece I think that is missing, and I will, just in the interest of transparency, say I haven't really been a part of the work group, so I don't know where they're at with this, but a big piece is informed consent that's often missing. That do these people know when they're calling this 988 line that if they say a certain phrase or they convey to the person they're speaking with that they're maybe experiencing a certain level of distress, that law enforcement may be called to their home, or that it may trigger other actions. If people know that and still choose to engage with that line, I think that's great, that's their choice. But if that isn't clear and transparent from the front, we're setting people up to be in real danger, particularly people from historically marginalized communities, people who are Black, Indigenous, people of color, queer, transgender, nonconforming folks. Interaction with law enforcement, particularly when navigating mental health distress, can often be deadly. And so with this sort of line, that really needs to be a transparent aspect of this.
Mm-hmm. We mentioned the youth mental health crisis, and you talked about some recent investments in children's mental health, but it really is a crisis. The Office of Children's Mental Health noting that insurance companies reporting 1,000% increase in claims for teens accessing that are experiencing self-harm, substance use between 2019 and 2020 in Wisconsin. What more needs to happen for kids, Dr. Immler?
And the data I'm aware of is a doubling, a 50% increase, but oh my gosh. Social connectedness has been recognized to be so important, and the Office of Children's Mental Health is really focused in that area to their great credit, because it's one of the major factors for kids in the pandemic was that isolation at a critical point in their development. So the social connectedness, again, looking at the social determinants of health and that affect communities of color more substantially, underpins this, so we see more challenges in those communities. Well, the access to care that's really sensitive to a child's needs. It's not just child psychiatry, but clinicians that are comfortable seeing kids can be really challenging. And a big gap in our state is substance abuse services for youth. The rates that the counties report are very low, and it really underestimates. So a certain amount of substance use isn't unusual, it may not be harmful, but if there's not support early on, it can evolve and a person experience things that they wouldn't have to.
Tim, thoughts on kids, supports that are missing for youth?
I think we're definitely moving in that direction, but a big piece of this is really recognizing the autonomy and validity of youth as their own decision makers. There's often a strong focus on the whole family, which there's nothing wrong with that, but it often falls on what do the parents want, what do the caregivers want, and less really what is the youth themselves saying they actually want. And really, I think when we can redesign systems to center the youth voice and the youth autonomy and recognize them as having an understanding of what they want and really being taken seriously as contributors to their own recovery, we'll see significantly more positive outcomes.
Dr. Immler, the Wisconsin Council on Mental Health often communicates with policymakers about what needs to happen, what needs to change. We're coming up into another biennial budget cycle in another year. Can funding fix this? What does the legislature need to do?
I wish it was as simple as funding. But a key part that the council strongly supported and has supported for some time is Medicaid expansion, so that there is access to care, a broad range of care, as Tim alluded to in terms of Medicaid eligibility. And that's often affecting parents where their children can access care where they may not because of limited income that they might not qualify for. So
there hasn't been a lot of political support for Medicaid expansion. Are you holding out hope for that, or you're just making the point that it would make things better?
Well, we're an island in the northern tier of states, and we're bright folks, high levels of education. One would hope that at some point there'll be a recognition, and there was some effort at a federal level to help those states that have been slow to adopt. So sooner or later it'll come, in part because of the cost benefit that's associated with access to care, including early intervention that Medicaid can support.
So you think Medicaid expansion could help with some of these gaps and provide more comprehensive supports to people?
Yes, and there's specific areas. The council recently supported a motion around something called dialectical behavioral therapy, which is a wonderful evidence-based practice that's group-oriented and individual and 24-hour access to support, a lot of psychoeducation and consumer empowerment around it, and not a one-way street. So we've supported that, and we're considering in a few weeks a proposal to fully fund the community support programs that ideally would adopt to fidelity the PACT model, which would be helpful.
And expanding kind of that localized support.
Yeah, and a really a broad menu of services is so important because consumer needs can vary so much. Our council in meeting on the 18th will be considering many recommendations, so I'm at a loss to be able to
We'll
share
come
all.
back.
Please.
Tim, part of statute around mental health, the Chapter 51, which kind of connects to the concerns you were talking about earlier about people kind of interacting right away with law enforcement and more restrictive sort of response. Does that need to change?
Yeah, I think there needs to be some major updates to how we're talking about crisis and crisis response. You know, there's been a big push in Wisconsin for trauma-informed care, for person-centered service provision, and I think we're certainly moving in the right direction. But to really see those things implemented thoroughly, it would require a re-exploration of what does crisis response look like, not just in the level of what do I personally think it should look like, but on that legislative level, on policy-making level, on programmatic levels. How are we actually responding to this? Who's being centered in this conversation, and what could that look like? So I would love to see that really being re-explored, and not just through that lens of specifically, you know, what we think it should look like as peer specialists or people providing services, but also what about the people receiving services? What do they actually think would be beneficial to them? And to me, that's really what needs to be at the core of all of these decisions about what these systems look like.
Tim, you and I talked before the show as we were preparing about how different cultures view mental illness. What can we learn from other cultures?
Yeah, well, I think there's been a really big push. You know, when we talk about equity or access to services, the response has typically been, you know, we just need more people of color who are therapists or more people of color who are certified peer specialists. But by doing that, we're just bringing them into a system that isn't really designed for them. And so what I would love to see instead is going to those communities and saying, like, you guys have your own understandings of these human experiences that we typically call mental health. And for centuries, you've been navigating them successfully. What are you doing and how do we support you? Rather than saying, in order to reap the benefits of this system, you have to come into it and assimilate. And we've seen that work, right? Indigenous communities have ways of navigating their own experiences. Black communities have communities that they support each other with. Queer communities have spaces that they can go to. All of these solutions already exist. And so it's less a matter of getting them to assimilate to how we understand mental health to be, and more about expanding our understandings to take into consideration what they need. The example I always use is hearing voices and seeing visions. A lot of people consider that to be really scary. It often gets considered psychosis or signs of schizophrenia, but other cultures see that as a way of communicating with ancestors or with the world around them. And so when we come in and say, this cultural practice that has meaning and value to you is actually a medical diagnosis that needs correcting, we're completely erasing their experiences and really not taking into consideration what they really need from systems that are meant to be serving them.
Dr. Immler, Wisconsin does have a variety of resources. We want to make sure as we're closing out our conversation that we share those. We're putting some up on the screen. What would you like people to know if they are experiencing behavioral health challenges or they want to support a loved one? What is your key advice to them?
To start from a position of hope and compassion, really listening. It can be very frightening, obviously, for the person involved, but for the family member. And that position of, I really want to hear where you're at, not say it'll be fine, but really hear. And then recognize that there are local supports There are regional NAMIs, and they have a program called Family to Family.
And we have that website for NAMI on our screen.
Great. And Mental Health America. Also, hopefully there's training in communities for question, persuade, and refer, QPR. It's a basic training, and some high school students are learning it, which is incredible, so they can support their peers. And their primary care provider shouldn't be forgotten, because ideally they would have access, I say ideally, have access to referral services.
Okay. Well, thank you both for joining us for our conversation about Mental Health Awareness Month. Clearly room for growth in Wisconsin, but some good things happening, so I appreciate your time today.
Thanks.
And thank you to the viewers of Newsmakers. Be sure to tune in again as we sit down with the decision makers and highlight the issues that are making a difference in our state.
This program was brought to you from the Margaret Farrow Studio.
This program is a production of Wisconsin Eye, an independent, nonpartisan, nonprofit media network with a mission to inform, educate, and engage the citizens of Wisconsin. Wisconsin Eye is the nation's first and only independently funded state civics broadcast network, providing gavel-to-gavel access to government proceedings and events at the state capitol.